This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am Nick Andrews. And welcome to episode 116 of Blood and Cancer. I am Nick Andrews, and I'm joined this week by the editor-in-chief of MDH Heme Onc, Dr. David Henry. And Dr. Henry, you called me while I was watching football this weekend just to make sure that you had everything ready for a presentation at a big meeting. And from what I understand, it still didn't go as smoothly as possible.
Well, I was getting ready. The ASH, the American Society of Hematology meeting, supposed to be in San Diego, of course, next week or so in December, are virtual. So we were lucky enough to get a poster accepted, and of course the whole thing's online. So you have very rigorous rules. You have to make it 5 minutes or less. You can only have 10 slides. And of course, nobody wants to see your picture. They want to look at the slides and listen to you. So I'm working with PowerPoint, and I think I was checking with everybody I knew, especially you, who are this geniuses to tell me how to get that picture out of there. So my first grade daughter teacher had to be over, and I said, Megan, what button do I push to make my picture disappear? And suddenly my picture disappeared. I said, Megan, what'd you do? She said, Dad, I unplugged your camera. So a word to the wise, it's always, not always electronic. It may be the simplest thing of all. So yeah, all recorded, good to go for it.
You got to make sure the power cord either is or isn't in.
Correct.
Yeah.
Correct. So you want your picture off, unplug the camera.
You guess you could put a sticky note over it next time. That'll work.
That's that.
Yeah, there you go. Maybe a little piece of tape. But we did make sure the microphones and the cameras were recording for our interview this week, which is about something that is abbreviated HBV, how to screen, how to treat, and what's going on generally there. So our guests, Dr. Arts and Dr. Huang, were your guests about, and we talk about HBV.
So I thought that really interesting. As always, I learn a lot when I do these interviews. And so hepatitis B virus is around. And it turns out we're all thinking of like rituximab can reactivate because of its suppression of lymphocytes and plasma cells. And maybe it allow your hepatitis B to come back from your liver if you're a carrier. Turns out most of our chemotherapy patients are immunosuppressed enough that could activate it by itself. They actually lobby in our talk and interview for doing this screening, and we go through which test to order in everyone because it may well activate and important to have a baseline evaluation. And in case you find it, we also talk about how to suppress and how to review their data and learn something about what can happen when you reactivate. So it was a really interesting HBV interview that we did.
Yeah, and of course we say HBV, and I want to make sure I'm pronouncing everything correctly, hepatitis B virus. As everyone knows, of course, there are show notes available wherever notes are found. Transcripts of the episodes are going to start to become available on Medscape. Depending on when you listen to this, you might want to check the notes. There may or may not be a link to a transcript available in the show notes, which is something that's pretty exciting. You can listen along if there is a transcript on Spotify. You can send that link to your friends if you think, because this is something we've had requested, Dr. Henry. People will like to be able to read the information, perhaps listen along, and so we listen. We're going to make that happen as often as we can, and hopefully pretty regularly moving forward. So you're a podcaster, but would you read transcripts? Are you a transcript guy?
Well, I like sometimes, I'll answer that by saying when I see a new patient sometimes and they say, well, all the data is scanned in. Well, there may be 50 pages scanned in, and going through it electronically I find very difficult. And if someone gives me a packet of 50 pages, I can go right to the place I want to be faster. So yes, I'm a reader, not just a listener. And so the transcripts would work for me as well.
Yeah, it's really strange. I found something very similar. So I'm a big e-reader. I like the Kindle Paperwhite, and I've read many, many books on that. I have some nostalgia involved there, but it's a weird feeling. You don't feel like you have as much control of the information when you're scrolling as you do when it physically exists. It's very bizarre. Even with a novel, I find that to be very true. So that's positive. And of course, you can print out any text on a website, whether that be Medscape or mdedge.com.
So true.
All right, so without any further ado, we're going to kick it over to our guests, and happy Thanksgiving to everyone. Dr. Henry and I are, of course, located in Philadelphia, which just said, hey, everybody stay home, and for everyone else that's in a hot spot or somewhere where the world is ending, stay in, stay safe, do what you got to do.
Be careful. See you, Nick.
Thanks, Dr. Henry.
I'm your host, Dr. David Henry. You're listening to Blood and Cancer, our weekly podcast on interesting issues for practicing caregivers in the hematology and oncology field. And today we're going to be talking about hepatitis B in hematology and oncology. And I always think to myself, is that a big problem? And fortunately, we have two people I'm speaking with today who know all about this problem. And so let me introduce them. Dr. Wang is Professor of General Internal Medicine, MD Anderson, co-chair of the ASCO Provisional Clinical Opinion on Hepatitis B. And her co-chair is Dr. Artz, who is an associate professor at the City of Hope and co-chair on this same committee of ASCO, and also director of aging and blood cancer. And I'd like to welcome you both to the program. Thanks for taking the time to talk to us today.
Thank you, Dr. Henry.
Thank you for having us.
Well, you're very welcome. And in this, we're recording this in late October, and sadly, our COVID numbers around the country seem to be getting to all-time highs. And so another virus of great importance is hepatitis B. So let's talk about that. And so I always think of the first thing is how often is this a problem? What's the scope of the problem? So, and either one of you can comment on how often does this come up as you're chairing and co-chairing this committee. How big is the problem hepatitis B for the hematology oncology practitioner?
Right. I think it's a big problem. I think if we look globally, it's a worldwide problem. Over 257 people have hepatitis B in the world. If we look at the U.S. population, if we look at the chronic hepatitis B prevalence, it's less than 1%. But if we look at the past hepatitis B prevalence, it can be up to 5 to even greater, maybe even 30, 40%, depending on the population. And
that was globally, you said really 270 million. Is that globally? Is that the number?
Mm-hmm.
Yeah.
Yeah, globally 257 million have chronic hepatitis B, much more for past hepatitis B.
Okay. And so, of course, that's globally the issue, and not all of those people, fortunately, are our patients. How common, maybe Dr. Artz, how common is this that we find this in our patients with cancer?
Yes. The cancer population in the U.S., on average, we think about 0.5% will have chronic hepatitis B. There'd be a range, maybe a little bit less, and somewhere around 5 to 10% would have past hepatitis B. I think, as Dr. Wang pointed out, it's going to vary widely, especially based on the risk factors for hepatitis B. So there will be high-risk populations where people may have been born outside of the country in endemic areas where it's quite common, and other places, of course, where it would be less common. And I don't know if Dr. Wang, if you want to elaborate any more on that.
Yeah, for sure. The prevalence of Hep B is quite high in those who have been born outside of the U.S. in various parts of the world, including Asia and Africa, South America. The prevalence is also high in persons who have a history of injection drug use, those who have household contacts of individuals who have been infected with Hep B in the past, men who have sex with men, persons infected with or living with HIV. There are a lot of risk factors, and if we were to screen based on risk factors alone, it would take considerable time and effort to ask all these questions of a person to ascertain whether they have a risk factor for Hep B or not. And many of these risk factors are, they're hard to talk about, maybe for the provider as well as the patient. So it is oftentimes difficult to ascertain infection status based on risk factors alone.
Well, so that then takes us nicely to that next question. So I'm a general practitioner in hematology, oncology, benign and malignant. So the clinic will have oncology, breast, colon, lung, and other solid tumors, and then benign and malignant hematology. So whom should I check? I guess you're saying I should ask these demographic questions, but since not everyone will be forthcoming, whom should we screen and check for hepatitis B status? Maybe Dr. Arts, you want to take that one?
I'm muted here.
The hazards of Zooming. It's
Yeah, absolutely.
on and off.
So that's the I think the major advance, what Dr. Wong just elaborated on, the challenges of screening in practice, and that's the major change and advance in this 2020 ASCO PCO, where we recommend universal screening for patients who are planning or undergoing anti-cancer therapy. And that has, as you can imagine, considerable advantages from a practitioner standpoint versus trying to evaluate a patient and potentially at multiple time points for risk factors of being exposed, and also trying to evaluate all the different therapies they're on and knowing if that's a reason to test for hepatitis B. So this, we recommend universal screening for anyone, for all patients with cancer undergoing anti-cancer therapy.
So that day, of course, makes me think, well, I better start doing this in my clinic if I want to maintain my ASCO membership and be adherent to your proposals and your guidelines. But so what am I sending? So I tell the lab, gee, take that extra red top and check off what test for hepatitis B or tests.
So, Dr. Henry, I would recommend that you consider 3 hepatitis B tests. One is the hepatitis B surface antigen. The other is the hepatitis B core antibody. And the third is the hepatitis B surface antibody. So just to break it down, the surface antigen and the core antibody, if positive, indicate a person has chronic infection. If a person has a negative antigen, but a positive core antibody, that means the patient has had past infection and once infected, this virus, a DNA virus, incorporates into the host genome, so it can live latently as covalent enclosed circular DNA. So it is always there and can reactivate. So whether a person has chronic infection or past infection, the person is at risk of reactivation after receiving immunosuppressive anti-cancer therapy. So the third test that we alluded to is the hepatitis B surface antibody, and that's a favorable antibody. If positive, can protect against complications. So if a person has past infection, that core antibody is positive, and they have evidence of a surface antibody that's positive, that would indicate that the person is at risk of reactivation, but the surface antibody likely attenuates the risk of reactivation, so it's protective. So our panel recommends all 3 screening tests.
Now, I've, of course, had my hepatitis B shot. What will be positive in me?
Yeah, that's a great question. The favorable surface antibody would be positive in a person who has had previous vaccination.
Okay. All right. So then, of course, now I'm going to implement my screening and try and discover people who have active past infection and, of course, worry about reactivation, as you just said. And I'm thinking, well, I want to give you rituximab or I want to give you a checkpoint inhibitor. Are the worries greater there? And could you maybe review, let's take rituximab. What test result makes you worry about reactivation, and how would you try and suppress that going forward, let's say with lymphoma?
Yes, you're exactly right that there's certain therapies that pose a very high risk or quite a heightened risk of reactivation more than others. Anti-CD20 antibodies such as rituximab, stem cell transplant, and there probably are others too. So if you are undergoing those therapies, whether you have chronic or past infection, we'd advise you to receive antiviral treatment for 1 year. While you're on treatment and a year after it, and then consult. This is an important part of our guideline that you see woven throughout, is that we recommend collaboration with the HBV specialist, recognizing that each patient's a little bit different, and when you want to individualize it and know some of the nuances, that partnership will help.
So I
do want to get back to the checkpoint inhibitor question, which you brought up. So those are the established therapies published data on very high risks of reactivation. We really dichotomized this into chronic hepatitis B, and those are the hepatitis B surface antigen, as Dr. Wong mentioned, and then past hepatitis B, where the risk of reactivation is lower but still there. So if you have chronic hepatitis B, pretty much any therapy you undergo, you're at risk, enough risk of reactivation that it warrants antiviral treatment and close monitoring. But for those with past hepatitis B, that's where you're looking at those who have the higher risk of reactivation, the CD20 antibodies, transplant to offer treatment. But other patients with intermediate risk, could be checkpoint inhibitor or other treatments with past, they're going to be monitored very closely. So they're all, either you're going to be treated or you're going treated and monitored or monitored closely.
So if we could pause a second on that checkpoint inhibitor, because we're still, I think, in our infancy of understanding how to use them, which tumors, many approvals, but then, of course, these little side worries like hepatitis B and checkpoint inhibitor. Do we have much data yet on, let's say you're a past infected patient and you get a checkpoint inhibitor for a while? Is there data to say how often that reactivation does occur?
Well, I think that the data is it's coming. There are case reports of really no problems, but there is a nice review of 120 patients who received checkpoint inhibitors, and if we just look at those studies and the patients who had a DNA that was ordered and who might not have received an antiviral therapy at the beginning of their anti-cancer therapy, it looks like the risk could be up to 20%. So more to come on that. I think this is an evolving field. I also want to mention that oftentimes patients who are getting checkpoint inhibitors have adverse side effects related to it, and they do receive glucocorticosteroids. And steroids are known to increase the risk of hepatitis B reactivation. So that's another independent risk of introducing reactivation in patients who are receiving this type of anti-cancer therapy.
And you and Dr. Artz mentioned to suppress and continue that a year after therapy. What drug or drugs would you use to make that suppression?
Mm-hmm. We in the PCO recommend one of three drugs, entecavir or one of the two tenofovir formulations. So there are two different tenofovir formulations. That's what we recommend. Those drugs are well tolerated and they have a low rate of viral resistance, which makes them quite favorable. And I want to add to what Dr. Wong said in the checkpoint inhibitors that are in practice. In addition to the need for steroids, which may increase the risk of reactivation, we also have autoimmune hepatitis, as we all know, and that really confounds your ability to continue therapy if you're not sure whether that's related to a viral hepatitis or from the checkpoint inhibitor. So that will definitely cause delays in your therapy if you're not sure why a patient has hepatitis, why they have a hepatitis. So that's another good reason to identify patients in advance and to know how to treat or monitor them.
So that could be really a problem because it can give you a hepatitis from the checkpoint inhibitor, as you suggest. Can you check an antigen? Would that pop and go very high if it's the hepatitis B as opposed to the checkpoint inhibitor?
Yeah, that's what we would expect, that if you have a hepatitis flare from hepatitis B, that the hepatitis surface antigen would be positive. But a lot of patients who have chronic, of course, they have hepatitis B antigen positive by definition. So then we're looking at the viral DNA and looking for increases in that. And again, going back to collaboration with a hepatitis expert, that's an invaluable time to collaborate with them to decipher what's happening at the level of the liver.
So, well, you've really gotten my attention. I need to start to do this in the clinic, and it raises the question of implementing a screening program. So I tell the lab I want to do it, and they go, well, how? So how? I suspect you've addressed this in your guidelines. So how are you recommending we in the general clinic seeing general hematology oncology implement such a program?
Well, we acknowledge that this is a new endeavor for many clinics and centers. And so I think there's going to be a lot of movement and quite a bit of innovation. So we're looking forward to that. But our panel does recommend a multidisciplinary approach. And there are definitely going to be human factors, increasing awareness, just like you're allowing us to do today, Dr. Henry. And in addition, I think the implementation through electronic health records are going to be very important. Trying to get alerts, perhaps, in systems or embedding them into order sets is a really great way to put it into an automated fashion. And I believe that the listeners will be able to really look back at their own clinical practices and how they collaborate across with mid-level providers and pharmacists, and especially ensuring that the positive test results are given back to the medical team who had ordered the result to make them aware, and then get them into the linkage of care that they're needed. As Dr. Artz mentioned, many of them are going to need monitoring for a very long time with collaboration with clinicians who are experts in managing Hep B. And oftentimes they're going to need that antiviral therapy, which should be, if needed, it should be started as soon as possible, but should not delay anti-cancer therapy.
So in working with ASCO and developing these guidelines, are they published, preliminary, or final? Where might listeners see these guidelines?
Yes. This is a PCO, and it is published. It's available in JCO, in print and online. And you can see the version online. They also have additional tools through ASCO that may help you to have a simple algorithm in the clinic to know what to do and help define perhaps some of these serologic tests that Dr. Wong alluded to. And I think it's really actually helpful. It's a little scary when the oncologist thinks about one more thing to have to do. But in clinical practice, as you know, Dr. Henry, trying to go back and figure out if or when someone was tested and whether they should have been tested, and resurrecting that is actually onerous in and of itself. And knowing that, oh, I'm just going to test at the start of therapy, it's uniformly done, I've evaluated that at that time point. I think there's a major value in that, to have that time point or time stamp where you know people are assessed.
Last week we recorded on antiemetics, and boy, we give a lot of steroids for antiemetics, and there you go in terms of possible reactivation. So I think we've covered most everything, unless you had another thing I forgot.
No, except, well, maybe one more comment. For oncologists, there's so many drugs that have developed in combinations, and we use them in sequence. So I do think this really simplifies it for people, because there was always a question about how immune suppressive is an agent or a combination. And I think by screening everyone, knowing whether they have chronic or past or no prior hepatitis B, that really helps guide what they need to do. And once they have the information, I think there is a figure in the JCO paper to help guide people about recommended treatment and monitoring. Using the hepatitis B consultant will help as well. So I think people shouldn't be overwhelmed. It's actually a little simpler than it sounds as far as screening and management.
Oh, okay, agree. Once implemented, it sounds automatic, as it should be. Well, I really want to thank you both very much for taking the time to do this. Certainly has taught me a lot. And we've been speaking to Dr. Jessica Wong, who is Professor of General Internal Medicine, MD Anderson, co-chair of the ASCO Provisional Clinical Opinion of Hepatitis B, along with her co-chair, Dr. Andy Artz, who is a Associate Professor at the City of Hope and Director of the Aging and Blood Cancer Program. Thank you both very much for taking the time to do this today.